My dear students, in this video, I am going to give you some examples and discuss salient points and features of some difficult to interpret ABG reports. Just it is a revision of things that we already know, but how things can fluctuate in different contextual settings is what is important to remember before interpreting the results. Let us start with the first case, the case 1. A patient is a 32-year-old woman of type 1 diabetes who has 2 days of vomiting, fever, and confusion. So it appears from the source that patient is having pneumonia and there are features of early septic shock. On presentation, there is Kushball pattern of tachypnea, that is with a respiratory rate of 34, which is shallow. The blood pressure is 88/52 and the temperature is 9.1 degrees centigrade. The ABG on room air shows a pH of 7.4, PCO2 of 20, PO2 of 78 and bicarb of 12. The labs reveal a sodium of 140, chloride of 100, potassium 4.6, glucose 468, and beta hydroxybutyrate 5.8, lactate 3.6. The key concern here is a normal pH of 7.4. And this can be often read as reassuring by the primary physician. And if you don't carefully look into it, you may miss something very important. So, why is this pH normal? Let us see the anion gap. The anion gap here is sodium of 140, chloride of 100, and bicarb of 12, which is 28. So there is markedly elevated anion gap, or there is high anion gap metabolic acidosis because there is raised ketone and lactate despite this normal pH. So if we apply the Winter's formula, the expected PCO2 would be about 1.5 into 12 plus 8 is 20. So it will be about 26 plus minus 2. So in the range of 24 to 28. But the measured PCO2 here, as you can see, is 20. So measured PCO2 is below the expected range, which means that there is a second primary respiratory alkalosis which is already present, which may be in this case because of sepsis-driven hyperventilation. It is not just compensation. So why this pH looks normal? This looks normal because this severe metabolic alkalosis plus the disproportionate respiratory alkalosis tend to balance each other. So these two derangements cancel out arithmetically, producing a falsely reassuring pH, which is not correct. So after recognizing this high anion gap metabolic acidosis and disproportionately hyperventilation, fluids were administered, insulin infusion was continued to correct the glucose, and empiric antibiotics were administered for the pneumonia. The lactate and the beta hydroxybutyrate cleared over 18 hours, with the ABG stabilizing to 7.36 pH, PCO2 of 30, bicarb of 70. So this suggests that a pH teaches us that a pH of 7.4 does not mean acid-base status is fine. We have to always calculate the anion gap and apply the Winter's formula even when the pH looks reassuring. When two large opposite direction or disorders exist, one can mask each other completely. So one needs to be careful about it. Let's move on case 2. A 58-year-old man with alcohol-related cirrhosis and malnutrition admitted with septic shock from spontaneous bacterial peritonitis presents in the ICU or is shifted to the ICU. The labs reveal a pH of 7.28, PCO2 of 34, sodium of 138, chloride 104, bicarb of 18, serum albumin of 1.6, and lactate of 4.2. Here, the observed anion gap, sodium minus chloride plus bicarb is 16. And this is often read by the initial team who is referring as mildly elevated and not concerning. Is it really so? Now here the observed anion gap is 16, it is true, which looks mildly abnormal at face value. But we also have seen that the albumin is 1.9, and each 1 gram per deciliter fall in albumin below normal hides a roughly 2.5 milliequivalent per liter of anion gap. So if you apply the correction by 2.5 into 4 minus 1.6, that comes out to be 6. So the corrected anion gap comes to be 22. So a clinically significant high anion gap metabolic acidosis or lactic acidosis was being underestimated by nearly a third. So this is very important. So in this patient, the corrected anion gap was prompted more aggressive source control, lactate guided resuscitation, and the repeat lactate fell to 1.8 millimoles per liter over 24 hours in parallel with correction of the gap. So the teaching is that hypoalbuminemia, which is present in roughly half of critically ill patients, systematically lowers the observed anion gap and can conceal a significant unmeasured anion acidosis. So albumin correct the anion gap whenever albumin is low, but not when the raw gap already looks high. So this is something, an important lesson one has to keep in mind. Moving on to case 3, a 46-year-old woman who is on acute and chronic liver failure and shock liver is on CRRT, that is CVVHD, with regional citrate anticoagulation for AKI. On the day 3 of CRRT, there is worsening acidosis despite an unchanged citrate dose, ionized calcium falling despite escalating calcium chloride infusion. The ABG shows a pH of 7.22, PCO2 of 30, bicarb of 12, sodium 136, chloride 98. The anion gap calculated is 26. The calcium is total is 11, ionized is, or 2.75 millimoles per liter, ionized is 0.78. Now, what is to be understood or considered before interpreting the ABG? Now here, if you see, the total to ionized calcium ratio is 3.5, which exceeds the 2.5 diagnostic threshold for citrate accumulation or citrate law. And the anion gap is 26, which is elevated. So this unmetabolized citrate is itself an unmeasured anion, and this widens the gap independent of lactate. So the mechanism which includes is an impaired hepatic mitochondrial citrate metabolism. Normally 1 millimoles of citrate leads to around 3 millimoles of bicarbonate. So failure to convert this citrate to bicarbonate produces both acidosis as well as calcium chelate, citrate chelation, leading to hypocalcemia. So this has to be interpreted from the ABG correctly in the context of this patient and the ratio of total to ionized calcium for further correction. So in this patient, citrate infusion was stopped, anticoagulation was switched to systemic heparin, ionized calcium normalized within 6 hours, and the anion gap closed over 24 hours as the citrate was cleared by dialysis. So the teaching point in this from this patient, that in patients with liver failure or shock states, a rising total to ionized calcium ratio of more than 2.5, together with an unexplained widening anion gap and escalating calcium requirements, should prompt evaluation for citrate accumulation before assuming under dialysis or worsening sepsis. Let's move into case 4, a 71-year-old man with severe COPD who was at home at an oxygen of 1 liters is come with a baseline ABG on file from the 3 months ago showing pH of 7.37, PCO2 of 65, bicarb of 36, and patient was earlier stable and chronically compensated. But since past 2 days, patient has been having worsening dyspnea with purulent sputum and is also drowsy at the time of presentation. And the new ABG shows a pH of 7.16, PCO2 of 90, and the bicarb of 32. Now, what is the hidden problem that we need to understand? Now, he is a patient of acute and chronic respiratory acidosis. If you look into his past ABG, if you see that the pH was normal at 7.37, but here also the expected bicarb rise, if taking at 0.35 milliequivalent per liter per millimeter mercury of PCO2 above 40 as chronic compensation check. So he was having a PCO2 of 65. So 24 plus 65 minus 40 is 25. That multiplied by 0.35. So which is comes to 33. And this is close to his known baseline that was 36. So his chronic ABG was already appropriately and near maximally compensated. So this is what is his personal normal in terms of compensation and the bicarb. So comparing that EBG with the ABG which is obtained today, the PCO2 has rose a further 25 millimeter mercury. That is from 65, it has come down to 90. But bicarb did not rise further. In fact, if you see, it has come down from to 36 to 32. So interpretation should be that renal compensation cannot accelerate within hours. So this patient had acute respiratory acidosis superimposed an already maximal chronic compensation. So pH fell from a compensated 7.37 to 7.16. For a PCO2 rise, by 25, the PCO2 rose, but this PCO2 rise, most people would tolerate with a smaller pH change. pH would not have fallen from 7.37 to 7.16 in majority. But a high bicarbonate is therefore not a safety margin once chronic compensatory ceiling has been reached. So this patient had already reached his ceiling, and therefore the safety margin was exceeded, and therefore the bicarb didn't rise, and the patient's pH fell drastically from 7.37 to 7.16. So recognizing true on acute on chronic decompensation, not his normal. So this triggered prompt NIV and treatment of the pneumonia trigger, and the PCO2 fell to 68 and the pH recovered to 7.34 within 12 hours. So the teaching point from this case is that in chronic CO2 retainers, always compare today's ABG with the patient's own baseline, which is available last, rather than population compensation formulas alone, because renal bicarbonate compensation is already near its ceiling in the chronic disease state, and it cannot buffer a fresh acute rise in the PCO2. So this is important, and that is why they would require NIV immediately. Moving on to next case, a 54-year-old man post out of hospital cardiac arrest or targeted temperature management at 33 degrees centigrade is mechanically ventilated. The reporting nuance is that the blood gas analyzer can report the same sample two ways, either by alpha stat, which is uncorrected measured report as if it is at 37 degrees centigrade, or pH stat, where the temperature is corrected to the patient's actual 33 degrees centigrade. So the alpha stat report was pH of 7.38 and PCO2 of 42. Temperature corrected pH stat equivalent from the same sample was of pH of 7.3 and a PCO2 of 53. Now, why these two numbers differ? Because CO2 solubility rises and the pH falls as the blood is cooled. So the analyzer must choose to report values as if at 37 degree, that which is alpha stat, or corrected to the true 33 degree, which is for the pH stat. And both describe the same blood sample. The difference is a reporting convention, not a new physiological event. But if we pick up the wrong target, if ventilation targets an alpha P stat of 40 millimeter mercury, the patient's true pH stat PCO2 becomes relatively low. Therefore, the relative hypocapnia at the patient's actual temperature causes cerebral vasoconstriction and which can further reduce the cerebral blood flow. So there is supporting evidence because crossover study comparing strategies in post-arrest hypothermic patients showed that the alpha stat strategy was associated with greater jugular bulb desaturation and cerebral oxygen extraction than pH stat at the same nominal PCO2 target. So it is good to go for the pH stat. So the team standardized on trending the temperature corrected, that is the pH stat PCO2 during the cooling phase, and adjusted the minute ventilation accordingly. So no further desaturation events occurred on serial jugular bulb sampling. So the teaching point from this case is that during targeted temperature management, we should know which convention our blood gas analyzer defaults to. Most report alpha stat or uncorrected. The same sample can look normal or hypocapnic purely depending on temperature correction, and this will have real implications for cerebral blood flow. And this remains an area of evolving evidence. It is not a settlement mandate yet, but this is in evolving evidence, and one should look into it and try to look for the temperature corrected PCO2 for targeting the mechanical ventilatory parameters. Moving on to next case 6, a 44-year-old man was found unresponsive at home and was presumed to be having sepsis, was empirically treated. He has altered mental status and tachypnea. The ABG shows a pH of 7.05, PCO2 of 15, bicarb of 4, sodium of 144, chloride of 100. So the anion gap is 40. The lactate is 3, which is only mildly elevated, disproportionate to an anion gap of 40. The serum osmolality, which is measured, is 320 milliosmoles per kg. Glucose is 90 milligrams per deciliter, and the blood urea nitrogen is 14 milligram per deciliter. Now, why is this discrepancy? Why only this lactate is mildly elevated despite an anion gap of 40? Lactate accounts for only a fraction of the gap and looks for there are other unmeasured anion before assuming severe sepsis alone. So the calculated osmolality is coming to around 2 into 144 because that was his sodium plus 90 by 18 glucose and 14 by 2.8. So that comes to around 298 milliosmoles per kg is the calculated osmolality. And the measured osmolality is 320, which means it is much more than the calculated. So the osmolar gap is around 22, which is elevated because the normal osmolar gap should be less than 10. So an elevated osmolar gap alongside an unexplained high anion gap metabolic acidosis is a strong evidence for a toxic alcohol, which can be methanol or ethylene glycol, even without a clear ingestion history. So fomepizole was started empirically pending confirmatory levels, and ethylene glycol level returned markedly elevated, and the patient required emergency hemodialysis but recovered fully renal function over a period of 3 weeks. So what is important teaching is that when anion gap is out of proportion to the lactate and the ketones, we should calculate the osmolar gap. But remember its mirror pitfall because late presentations of toxic alcohol poisoning can show a near normal osmolar gap because the parent alcohol is progressively metabolized into acidic and osmotically silent metabolites. So a normal gap never fully excludes toxic ingestion. Therefore, we have to look for the osmolar gap, and if required, we take necessary measures of dialysis or drugs, etc. Coming to the last case, the case 7, 39-year-old resident of a high altitude town in Himachal Pradesh who has no cardiopulmonary disease is transferred to a sea-level ICU for community-acquired pneumonia. On arrival, the ABG, the room air, pH is 7.3, PCO2 is 30, PO2 is 58, and bicarb is 20. The key concern is that the medicine team which attended flagged this as respiratory alkalosis with hypoxemia requiring urgent workup. Now, if you see what is normal blood gas at an elevation of 3,500 meters from where the patient has come, the expected PCO2 for chronic hypoxia following altitude acclimatization relationship is 0.25 into PaO2 plus 15. If we take this forward thumb rule, then it is 29.5 millimeter of mercury. So the measured PCO2 of 30 millimeter of mercury matches almost exactly what is expected for this degree of chronic hypoxia. So interpreting the apparent alkalosis, now bicarb 20, which is mildly low with a pH of 7.3, which is mildly alkalemic. But this is the patient's expected chronic renal compensation for years of altitude-driven hyperventilation. So this is not a new acute derangement from the anemia, from the pneumonia, but this is something which the patient has been living for years at his hometown. So what would actually be abnormal if the PCO2 or PO2 materially different from his own likely baseline? It would have been different. And any further deviation, not the absolute numbers, is what should trigger concern for acute decompensation. Till that time, it is absolutely safe. So the ABG was correctly reframed as consistent with expected chronic altitude physiology. Management was focused on treating the pneumonia, and a repeat ABG thereafter confirmed a stable and expected baseline. So the teaching point is that ventilatory acclimatization to chronic hypoxia, which occurs at high altitude or which also occurs in chronic lung disease, resets the normal PCO2 PaO2 relationship. So applying sea level ranges to a chronically hypoxic patient can wrongly flag their baseline physiology as an acute abnormality due to decompensation. So treat the altitude acclimatization relationship as a physiological teaching guide rather than formally validated bedside algorithm. And always correlate with patients' trends and the clinical picture. Thank you.